I would like to introduce my two colleagues today who are actually physically at Willowbrook, two social workers. We have Haley Stein, who is also the district project manager, and then we have Brittany Hayes, who is the regular district social worker over at Willowbrook. I'm Marshall Getz. Usually I'm based at HMH, which I am today, and I'm the educator for the program. And what we would like to talk to you today is about our suicide policy and what you need to know about it to keep your patients safe. So we move to the next slide. And I realize that most of you are going into more physical medicine, or you're going into the emergency room. And so whether you're in that or whether you're in the emergency room, you are going to see behavioral patients. That's a fact of life. You cannot avoid the psychiatric side by sticking to the physical side. And like we tell the psych nurses, it's vice versa. They can't ignore the clinical medicine side just by focusing on mental illness. You're going to get both no matter where you are. So suicide rates, it's no secret they're rising. And with the current stress of the pandemic, there's an even greater risk of suicide right now. And so the last statistic that we've got here is 90% of the people who attempt suicide have a mental illness. And I think that's a bit of a lie. It should be closer to 100%. It is not a normal thing to commit suicide or make an attempt at it. So we're talking about something going on. And of course, the next one is that 25%, 1 in 4 people with a mental illness have a substance use disorder. And that's not a big surprise. That's self-medicating. Either they don't have normal health care, or it's not available, or it's too expensive, or they've been given psychiatric medications and for some reason there's a side effect, they don't like it. So they're using street drugs or alcohol to curb their symptoms. And I don't even have to say much about opioids, because if you're in the hospital for more than 5 minutes, you're going to be exposed to pain-seeking patients. And so opioid-related visits are very much on the rise. Doesn't surprise anyone. With all the scandal that was associated with the Sackler family and their pharmaceuticals, it's the oldest model that we've got since the Opium War in China. You've got an addictive chemical that's easy to produce and cheap. What's so painful about this is what it's done to people. And also, and I'm going to date myself, in my day, when we talked about drug users and so on, we were warned to stay away from the bad kids at school. That's simple. Just stay away from the bad kids at school. They're probably using drugs. This new generation of people who are hooked on opioids got them from their doctors. They weren't doing it to have fun. They weren't doing it to be cool. They weren't doing it to go against society, all right, or rebel. They were given a prescription from their physicians, and it just wasn't maintained right. So they're going to come into the emergency room, and you're going to know them when they start giving you the dose, and they start telling you what works and what doesn't work, and they know more about pharma than you do. You know you have a live one. And comorbidities are extremely prevalent among the mental health community because it's just harder for them to take care of themselves. So they do have physical illnesses, heart attacks, lung conditions, GI stuff, liver conditions, kidney conditions. They may even be transplant patients. So you've really got to be on your guard for this. So what do you need to know about inpatient suicide? First of all, a statistic that's not on this slide. Right now, suicide is the second leading cause of death after accidents with young people. So it's extraordinarily serious. And inpatient suicide, it's rare, but it does happen. So it is cause for concern. So, generally speaking, suicide ranks 11th in causes of death in the USA across all ages. I love that red, highlighted in red statistic. The Joint Commission found that successful suicides were the second most frequent sentinel event. The first one being wrong site surgery. Now, there's a huge difference between the number one and the number two. There's a big gap between them, but it's interesting that successful suicides made it to number two. So, what do you need to know about that? That's what we're about to help you with today. So, you're going to you could see this on any unit, not just psychiatry. And what's putting it at increased risk? Okay, so it can be an illness, neurological ailments, which pairs right in with pain and disability. So it's very common for someone to get a bad diagnosis and to say, all right, if this is what's going to happen to me, I'd rather die. If this is what's going to happen to me, I may try something. And when it comes to paralyzed patients, very often that is their first reaction. I've been paralyzed, let's say it's an accident. Okay, I'm not going to live this way and I'm going to try and kill myself. So be aware of that. Now, the root causes, this is a really key slide here. DSRIP is all about, and I'll explain what that means in a moment. DSRIP is all about doing screens. If you don't take the screens seriously as nurses, you may very well be missing something. All right, so we have screens put in place. We'll be talking about those. Use them and use them right. Sometimes it's an incomplete physical assessment, so the patient's actually holding onto something. They may have something in their mouth, they may have something wrapped in their clothing. In some cases, I know sometimes there's, it's physically on the person. So it's really, really important that you be mindful of that. Within the environment. Now, we'll be talking a lot about this morning. A hospital room is one of the most dangerous things around, and you cannot remove every single thing. You would have the person in a box. But you've got to watch out for the risks, try to mitigate whatever you can, and when you have a sitter in the room, that sitter had better be on his or her game. And training of sitters is very important, and we talk a little bit about that too. So there are suicide risks assessments. Sometimes it is simply the easiest when the patient, just listen to the patient, and the patient is actually telling you, I would like to hurt myself. Or I've had a history of hurting myself, and this is what I came to the hospital for. And you can certainly ask, are you thinking of killing yourself? Excuse me, water time. One thing I want to say right off the bat, you cannot inspire a patient to kill themselves by asking about it. Okay, that doesn't work that way. More often than not, they're thinking about it and they may not be vocalizing it, and they may think they're the only one on earth who's feeling this way. It's so strange. And when you ask them about it, you're opening the door to help. So this, I know, bothers a lot of nurses. You've got to go there. Absolutely, you have to go there. We've got a list of verbal cues. They may be talking about it, especially the idea of hopelessness or embarrassment or burden to others or, the way out kind of thing. So you need to communicate that with the rest of the team. If you are lucky, a mental problem may be actually documented in the history and physical. Or you may see that they're taking medications. Now, the medications thing is a little bit iffy because there's so many off-label uses for psych meds and all the other meds. I may be taking Prozac to help me sleep. I may be taking Prozac to help me with weight. I may be taking Prozac for a pain issue. So you really have to say, I notice you're on X. Why were you given this script? And so check that out. Now, the main types of mental illness, this is actually my favorite part of the whole program. All right. I could drive you nuts. There is a gigantic book called the DSM, the Diagnostic and Statistical Manual, that psychiatrists have put out. It comes out through the APA. And there are almost 300 diagnoses of mental illness. Almost 300. They couldn't make me happy and make it an even 300. It's just under. The good news is most of those you're not going to see in a hospital setting. Things like fetishes and so on. You're not going to see that. The ones that we've got listed here are really the biggies. And so those are the most common ones. And so we'll take it one at a time. Depression. So what is depression all about? Depression is just what you've heard. I mean, it's the blues, it's feeling bad, it's I'm in a low mood, all the different descriptions are true. And so depression is something to be aware of. Now, if somebody is maximally depressed, you're not going to see them unless somebody has physically picked them up and taken them into the hospital. Because if somebody is depressed to the nth degree, they're not getting out of bed. They may bother to eat, they may bother to get up to go to the bathroom, or they may not. It's when they're just getting a little bit beyond above maximally depressed when you may see them. And it is potential that they could be suicidal. All right? So the various levels of depression, all right, it's a matter of degree. Some of the other symptoms that go with depression are possibly suicidal thoughts, possibly changes in eating. They may eat more, they may eat less. They may be sleeping more or sleeping less. And it's interesting that depression, when it's in an older person or a very young person, may show up more as irritability than the blues. So depression is one of the big ones. The good news is about depression, if someone is getting some kind of talk therapy and they're on a good antidepressant and they stick with it, there's an 80% chance or higher that it will go into some form of remission. So that's pretty good news. And that's something you can share with, with patients. The next one's anxiety, and I think that's kind of interesting. Compared to depression, and depression is just a matter of degree. It looks like the blues. Anxiety, there are a whole bunch of different varieties of it. So we can have something which you probably won't see in a hospital, a phobia, where I'm only afraid of one thing, dogs. Okay, and there's nothing else that bothers me and nothing else makes me anxious. And so that's it. I live my life by avoiding dogs. And of course, that screwed up my veterinary career, but it is what it is. So just to another kind of anxiety, where I may be just afraid of speaking in front of people. Okay, and that's a different thing. Or a social anxiety, where it isn't just I'm afraid to speak in front of people, I'm afraid to be around people, and it starts to make me uncomfortable and I can't function. All the way through to agoraphobia, where people are just not leaving their homes and they become shut-ins. So anxiety can vary. Anxiety may be part of me being sick. I'm worried about this diagnosis. And what may happen with either depression or anxiety is if it's being triggered by the fact that I'm sick, I may not be able to hear you say what I should be doing. You're telling me what I need to do to get better, and in both cases, I just shut down. I can't function. Now, bipolar, some people have said that bipolar disorder is the diagnosis du jour, where too many people are diagnosed with it. Typically, bipolar patients are more often depressed than in the manic stage, but all it takes is one manic episode and you get that diagnosis. Some cycle where they go from depressed to manic. Some patients may only have one manic episode, and most of the time they're at some level of depression. So it's the manic episode that gets the attention. I don't have a good statistic on this, but I can tell you what a manic episode is not. A manic episode is not bad behavior. Okay, some people have automatically claimed that I must be bipolar because I've done something that I'm ashamed of. If at the next Christmas party, you go ahead and you get drunk, and you tell the boss off, and you tell the boss exactly what you think of him or her, that's not being bipolar. That's getting drunk and misbehaving at the Christmas party. If I get stopped by a police officer who is of a different race than I am, and I start in with the racial stuff and I get arrested and it's, oh my gosh, that really isn't me. I'm so ashamed. I must be bipolar. That's not being bipolar. That's being a racist. So there have been a couple of celebrities that have claimed this, I must be bipolar because I did something wrong. No, it isn't. A manic episode best looks like Robin Williams, his comedy. Now, he was obviously a troubled individual. He talked about it. Brittany, I believe, sent me a really nice quote from Robin Williams talking about, his dark side and the things he dealt with. I don't know if he was ever diagnosed as bipolar, but he definitely showed that flavor in his comedy. His comedy could exhaust you as much as it exhausted him watching him do it. They flit from different things. There may be pressured speech. They may have done something that bumped up against society, like trash a hotel room or max out on credit cards. But really, the one that tends to be the hallmark is the cardinal symptom. They stop sleeping and they're not getting tired. They may tell you, I've been up for 3 days straight and I feel great. And they're not on caffeine and they're not on no-dose. So that's one that really you have to hold on to. Now, we all can miss sleep, but we feel badly the next morning. Okay, we've all been students. We've all had the big project that we let go to the last minute, or an exam we didn't study for until the last minute. Right, but we felt lousy afterwards. These people keep on going. They're like the ever-ready rabbits. But eventually they will crash. The next one is schizophrenia. Now, it's a psychotic disorder, okay? But it's the biggest chunk of psychotic disorders of the schizophrenia spectrum. In the case of a schizophrenic, they have broken with reality. It's a thought disorder, and they don't know what's real anymore. Okay, and that's super important, and it's super scary for them. When a schizophrenic is on their meds, they pretty much are withdrawn and they pretty much want to be left alone. It's when they go off their medications that they start to have those kind of positive symptoms. Now, what are the positive symptoms? There's two big categories of them. There are the hallucinations, and in which they seem to be responding to a stimulus that's happening internally. And so you can ask them, are you seeing things or hearing things that other people are having trouble seeing or hearing? The most common kind are the auditory hallucinations, and the most dangerous of those are command hallucinations, where you ask them, is somebody telling you to do something wrong? Or is God telling you to do something wrong, hurt others or hurt yourself? That's the auditory hallucinations are common, but the command hallucinations aren't necessarily happening. But you want to ask about that. There are some weird ones. Some people have tactile hallucinations where they're feeling it rather, like bugs under their skin or broken glass or sand under their skin or something's touching me that isn't touching them. And then there's also olfactory hallucinations where they smell something funny. I may be smelling gasoline or fire or fecal material. That can also be something neurological. So if that's the big feature, I'm smelling something that isn't there, something may be going on with their brains. Now, it's very interesting. It wasn't until I came to Methodist that I saw this diagnosis, bipolar schizophrenia or schizophrenic bipolar. Those are two separate things. Bipolar comes under mood disorders. Schizophrenia, as I just said, is under thought disorders. Why are you putting the two things together? They don't go together. And yet, when a schizophrenic is off their meds, that is how they act. Before I told you, when they're on their meds, they want to be left alone. Mainly because there's so much going on inside them that they don't necessarily know what's what and what isn't. When they're off their meds and you see that kind of bipolar feature, they may get into your face. And I'm sorry, I'm not very well organized today. I forgot the second big positive feature are delusions. So they may be sitting in the emergency room telling you the government is out to get them, the TV is talking to them and only to them. What else? Something's happening that's all about them, big government conspiracy, the FBI, the CIA, and so on. And no matter what you tell them, you're not going to change their mind. It's a delusion, and they're in there. They may also have delusions of grandeur. Now, some bipolar manic people may be acting almost the same way, where I'm a multimillionaire, you don't know it, but I'm Beyonce's husband, I'm the real husband, and so on. And that's what they're talking about, and you can't change their minds. The other psychoses out there may be drug-induced. They may have gotten into some kind of a poison. It may be something even organic. Something is wrong with their brains, and so they're showing these psychotic type features. Alcohol drug abuse is what it is, and postpartum depression is very much, related to pregnancy. Okay, and so that's a special kind of depression. So these other things, patients may be saying something, they may be acting out. You may see mood swings in just the time it takes to take care of them. 1 minute laughing, 1 minute crying. They're not necessarily dangerous. They are not necessarily, when they are dangerous, they're more likely to be dangerous to themselves than to other people. But you do need to watch them, and you do need to be careful around them. Okay. So let me turn this over to colleagues, all right, what our policy is about, okay? I'm not hearing my colleagues.
Hey there, Marshall.
Oh, okay, good. All right, now I'm hearing you. All right.
I think we're going to, unless do you need to break back in at some later point, or can Haley wrap it up?
I was going to break in when we started talking about, kind of the value of the screens.
Okay. So I'm going to, let's see. Okay.
Oh, we can just call him back if that'd be easier.
I don't think it's necessary. I think we can leave it as it is. I think that instead of him sharing the screen, we're just going to use his audio. And I think we're going to start using the presentation from here instead.
Okay. Should I click stop share?
Yes, please. So, is it a different presentation?
I'll still stay on computer audio, okay?
Yeah, that's perfect.
Let me see. We had sent a new one.
Yeah, I believe you did, huh?
Mm-hmm.
Okay. Marshall, could I bother you to email us the PowerPoint you're using? I know we've got it, but I just couldn't put my finger on it.
I'm going to email it to you right now.
Thank you.
Yeah, it has the newest info from the policy
Yeah.
update.
No, I was like, this is June. Everyone I kept finding was June. I'm like, I feel like there's
I can't remember when we sent it. It would have been like a month ago. My last March. Yeah, that was the one we sent.
So I think I can pause recording.
Okay. Need some stage lighting.
My background.
Okay. All right. So I'm going to talk about the policy that dictates how we treat, assess, and the procedures related to patients who are in the hospital who have suicidal ideations. And so the policy that addresses this is the PCPS 180. It's the Suicide Risk Assessment and Mitigation Policy. It has been approved and it is now available in Policy Tech. And so what this policy does is it looks at the PHQ-9, which is a 9-item questionnaire that looks at asking the patient over the past 2 weeks, have you had any symptoms of depression? So while the screen's mostly for depression here.
Yeah.
I'm sorry.
Would you, so yeah, I think it's like, it actually comes like, it's very sharp angle like that. So if you,
Yeah, sorry, would you like?
what would you be more comfortable doing? Would you rather have the clicker and be over here? Or would you rather
Oh yeah, no,
glue
that's,
yourself to
no,
that?
no, no, that's
Okay.
easier over here. I just wasn't sure. I was like,
Can you check the clicker? I'm not sure whether it's,
oh yeah, okay.
and then.
Okay, so here's where Marshall would want to come back in at the screen.
Can I have you?
Yes, yes.
Yeah, I like that. I like that much better than podium. So
Okay,
it
go ahead,
looks
start.
good. No, just go for it.
Okay.
Hold on. Okay.
Okay, so the PHQ-9 is a 9-item questionnaire that looks at the risk of depression for your patients over the past 2 weeks. So my coworker Marshall will go a little bit more over the science behind the questionnaire, but what I want to address is question 9. So question 9 is the pivotal question that the suicide risk assessment policy is based off of. And so what question 9 asks is thoughts over the past 2 weeks that you have thoughts that you would be better off dead or hurting yourself in some way. And so the answer categories that a patient can choose are no, not at all, which would be 0. 1 would be several days over the past 2 weeks I had these thoughts. 2 would be more than half the days I had these thoughts. And 3 would be nearly every day I had these thoughts. And so what these answers do is it puts your patient in a suicide risk category. So this is called risk stratification. And so if your patient answers 0, no, not at all, I haven't had any thoughts, great. They're not going to be in a risk category at all. If your patient answers several days, that's going to put them in our low risk category. And if your patient answers a 2 or a 3, this will put them in your high risk category if they're 2, or your imminent risk category if they're 3. And so what we'll do is we'll go over the steps you'll need to take if you have a patient who is low risk, high risk, or imminent risk, and how those vary between the risk levels. And so here's for screening. So my coworker, Marshall.
Yes, you want me to talk about that?
Yes.
Okay, thanks. Well, this is what it looked like, and it's an interesting screening tool because it was built into Epic, so we were going to use it no matter what. But it's got some very good statistics for measuring depression. And turns out it's also good for measuring anxiety as well. So it could be that people who are sick have both depression and anxiety. And so when we talk about the statistics behind it, there's 2 main ones that you want to have: reliability and validity. Now, a mood can change. Reliability means when you use this tool, is it, if we use it now and we use it again in 5 minutes, you shouldn't have that quick a mood change. Would you get very similar results? And you do. So in other words, if Haley were to give this to a patient, and then maybe an hour later, a nurse comes in and gives it to a patient, the same thing, you get the pretty similar results. The other consideration you want is validity. I may have something that gets the same answer over and over again, but am I measuring what I want to be measuring? And the answer to this is yes. Okay, it is valid and it is reliable. And if you look at the Cronbach alpha, maximum is 1. Studies show this is a 0.88, so that's pretty good. It's pretty strong. And there's also statistics on that question 9. When people say that they are, that they're flagging on question 9, there is a statistic that shows they are at increased I'm sorry, I'm talking too fast. They are at increased risk for hurting themselves later on within a 6-month period. So you do want to pay attention to your PHQ-9. Okay, thank you.
Okay, so now I'll kind of address what are going to be happening in these risk levels that we talked about earlier. So when you have a 0 and your patient's at a no risk, we're going to go ahead and just reassess with the PHQ-9 if the patient has a behavioral event, or always if you trust your nursing judgment, if you feel like something was off, maybe the first screening didn't feel correct to you, or maybe you overheard the patient, make some commentary that makes you believe, hey, we should just go ahead and screen this patient again. Absolutely. Repeat that PHQ-9. It's there. It's available in your nursing tools. But otherwise, if you have no reason to believe the patient needs to be rescored, you can go ahead and realize this screening has been done for this admission. Low risk, if the patient scores a 1 on that question 9, we're going to go ahead and ask that you rescreen the patient daily on the 7 a.m. shift until that question 9 score is a 0, or until the patient is transferred or discharged. Now for a high risk and imminent risk, these are going to vary slightly but look very similar, and I'm going to highlight that key difference. So with the imminent risk patients, you're going to immediately implement suicide precautions. You're going to get an order for the suicide precautions, and you're going to continue to screen daily on that 7 a.m. shift. And so the difference is going to be with the high risk, we're asking you to consider implementing all of these steps for your patients who are imminent risk. So again, you're going to want to talk to the physician, decide, hey, for this patient, they are high risk for suicidality, given that they answered a question and they had a result of 2 on question 9. And so are these the steps do we want to take? Do we want to go ahead and get that one-to-one sitter? Do we feel like after talking with the patient, they are, at high risk of immediately maybe having a suicide act? And so that's going to be that big difference. We get that asked a lot. So imminent risk, again, just go ahead and implement everything right away. You're going to get that one-to-one sitter, the suicide precautions. High risk, we're asking you to talk to the attending to consider taking all of those steps. And I'm going to go over the procedures for when you do have a patient who is on suicide precautions. So when you have that patient who is suicidal, when you answer the question 3 on question 9, it's going to trigger this suicide risk order set to appear. And so this will have in here an order for the suicide precautions, in order to consult social work, and in order to consult the mobile assessment team. And this is what that BPA is going to look like that fires on your end. So if you can't remember all the precautions that are listed out, it's okay. This will be a BPA that fires that goes over each of these in detail to help remind you, hey, here's all the steps that we recommend to make sure your patient is as safe as possible while they're in the room with you. And so those suicide precautions will need to be implemented immediately once the need is determined. So as soon as you screen that patient and you realize, hey, they are at imminent risk or they're high risk, and we talked with the attending, you want to get those ordered right away. And when you order those, just remind the patient, hey, these are going to be for your safety. And so, all of these steps we're taking, we realize it's not fun for anybody. We realize, it can be upsetting or just kind of emotionally involved when we're doing these steps with these patients, but just remind them it's here, it's for their safety, and we're doing the best that we can for them. And so with this, we need to get the physician to write an order within an hour of you implementing the suicide precautions. Those suicide precautions do need to be looked at every 24 hours to make sure that we're still doing right by the patient, that this is something that's still needed for their safety. And we must discontinue the orders prior to discharging. This is especially important because we don't want it to seem like a patient was, if we have them on suicide precautions and they're getting ready to discharge, that means that they were not actually safe for discharge. We cannot discharge someone home on suicide precautions because that implies that they were still not safe enough to be without someone watching them on a one-to-one. And so obviously exceptions to this are when a patient is going to be discharging to an inpatient psych facility. We still need to discharge those and those orders right away before they leave. And so we'd also like to remind you to talk with the attending about ordering telepsychiatry. Later on in the presentation, we'll kind of go through the steps to order the telepsychiatry for those of you who may not be familiar. I know in the emergency room, our nurses there use it pretty frequently. And you have your own JSA iPads located there in the ED. And then you also have iPads listed in the OA's office for those of you who are on inpatient floors. So in those precautions, we're going to review the precautions that we're going to take when you have a patient who is on suicide precautions in the room. And so first and foremost, you're going to want to look over the patient's room to make sure that we've removed any obvious items that can be used to hurt a patient or hurt themselves. Obviously, we cannot remove every item from a patient's room. These rooms were designed to have medical patients in them. They were not designed to treat psychiatric patients alone. And so with that, the biggest thing that we're going to have is that one-to-one sitter in the room, constantly watching the patient at all times to make sure that the patient is not able to hurt themselves. But the steps that we can take to mitigate those risks are going to be making sure that we remove any items in the room that the patient could use to harm themselves, including any belts, shoelaces, any needles that they might have access to. Any items like that can be given to hospital security. And then we're going to place the patient in paper scrubs or a stringless gown. I do believe here they have paper scrubs. I ask all of you guys to get with your charge nurses or unit managers and ask them where those are located on the unit. So that way when you have a patient who's admitted, you're not scrambling at the last minute to try and figure out where these items are located. We're also going to request a safety meal tray. So what that is you'll pull up that existing dietary order that you find in Epic for your patient, and you'll go to, there'll be additional instructions. You can click on that and click the safety tray order. So with that, what you'll need to do is make sure that the tray that your patient receives is a paper tray, no soda cans, no real silverware. You want to make sure it's plastic silverware, styrofoam cups, styrofoam plates. Just make sure that it looks like the safety tray that it should. And if for some reason you do get a tray that is not, you notice, hey, they still left a soda can on there, or they delivered it, but it still had real silverware on it, please let dietary know. These mistakes happen from time to time, and so we all need to learn together what these safety trays look like. And so please let dietary know if you notice a tray comes back that is not fitting these requirements. And then we'll also launch the suicide treatment plan in Epic so we can track the patient, make sure that we're making progress towards their goals. In regards to medication, make sure that after you administer medication to the patient that we check for cheeking. Okay, so one-to-one center is the best way we have to mitigate risks with our patients. And so we want to make sure that we have a trained one-to-one sitter there throughout the entire admission. So the sitter needs to be in the room with line of sight observation on that patient at all times, even when they go into the restroom. And so we will want that sitter completing a Q15 form. So this Q15 form is a paper form that will be scanned into Epic that identifies exactly where the patient was at 15-minute intervals throughout the day. So if that patient was eating, sleeping in the restroom, standing up in their room, we want to make sure that that's tracked throughout the day. And so here's an example of that Q15 log. So you can see it has the 15-minute intervals throughout the entire hour. And then it also has codes for both the location where the patient was and what the patient was doing. So any behavioral codes like crying, what the patient, how did their mood look throughout the day? So we can track, are we seeing improvement while the patient is here? Or are we still noticing, are they crying excessively throughout the day? Because these are still vital. This is how our techs and our sitters help us in tracking the patient's progress and really providing that collateral information. And so while it may seem like this is, just one way to track where the patient is, it still helps us in following if the patient is improving in their treatment goals. So very important that this is completed and scanned in. And so in keeping that in mind in ways that we keep our patients safe, we want to make sure that when we're interacting with our patients, we interact with patients in a way that also keeps our staff safe as well. And so what this includes is, remain close to the patient, but be closest to the door. Stand sideways, kind of in the way that I'm standing right here, to make sure that you're not in a position where you could be cornered into a corner of the room, or maybe in a position where the patient could easily exit the door and you would be left in the corner or, in the room in a position that's unsafe for you. Always be direct, set limits. That's one of our biggest things. We want to stay direct with our patients, especially when there is, this is an emotional event for a lot of our patients who are maybe being seen by psychiatry or are experiencing these suicidal ideations. The last thing we want to do is be vague when we maybe have access to more information. And so we just want to make sure that they know this is for your safety. This is what's happening. We had telepsychiatry see you. Just kind of confirming these things with these patients is to not allow them to kind of interpret, maybe different ideas of what they think may be going on. Call for assistance. So assistance does exist. You don't have to go in alone if you need extra help. That is there. You can ask your unit charge nurse, you can ask your manager, and if needed, there's always security backup available. And so that is done through calling a code purple if needed. And as always, report any injuries and debrief after. So here's some examples of mitigating those risks as we talked about earlier. So we have a few photo examples of some risks you can see in the room. So we have, the telephone cord. This is going to be an important one. Obviously, it's not possible to remove a lot of these. So that telephone call bell, that cannot be removed, but we need to be aware that this is a cord near the patient that they could use to hurt themselves. Looks like an Ethernet cord we have down there. Lots of sort of wiring happening around these patients' beds that we're not able to remove for safety reasons. And so we need to be aware of these and have your eyes on them, make sure your sitters are aware of them, do a once over with these sitters. Hey, look together, realize, hey, these are the risks that we're seeing. And we need to make sure that we don't, the patient's not going for them. If they do, redirect the patient and call for help if needed. They're just circling those risks again. Another risk is going to be in the curtains in the bathroom. So this is why those sitters will still need to remain with their eyes on the patient even when they go into the restroom. Again, this is for their safety. I realize it's uncomfortable for patients, but ultimately we need to do right by the patient and what's safest for them. Other risks include, bags that may be in the patient's rooms, hinges, hooks. The door handle is one that can be used as a ligature point. So just be aware of these. Again, we understand you cannot get rid of every possible ligature risk or any risk to the patient's safety in the room, because these rooms were designed to treat medical patients. So the only way you're going to avoid them is if they are in the psych safety pod in the EDs, but the vast majority of us are going to be on the inpatient units or in regular multi-purpose rooms in the ED. So that's that door, the door hinge. So things can be wrapped around the door hinge. So that's why we point out a lot of these. because we've seen it happen or we've heard about it happening. So we just want to pass on those risks. The shower, again, the shower is going to be another example of that ligature risk. The cord pull for the blinds. So again, line of sight observation, make sure we're here, make sure you have that one-to-one sitter at all times to help mitigate these. One important topic I do want to address is the environmental services cart. So this is one that's come up in topics recently, making sure that for these patients, the EVS employees do not bring the cart into the patient's room. I know here we go over that a lot, especially at Willowbrook. You know, the staff is fantastic about this, but just be aware that this is, hospitals in the Harris County area have been cited by this for DNV, that patients had access to these chemicals that were on these EVS cards. And one patient actually told a surveyor, hey, you know, if I wanted to, I had access to chemicals every time they came into the room. It was right there. And so keeping, you know, making sure that these carts stay out of the room and that the patients don't have access to it. Again, environmental services is great. They also know they maintain eyesight on their cart that's outside of the room, but just to be backup information. Visitation, so patients are allowed to have visitors. This is something that comes up pretty often. You know, my patient's being held here, can they have a visitor? Yes. While they're here on the inpatient units and in the ED, they can absolutely have a visitor that comes to see them. They can also have access to their cell phone while they're here. The only reason why they cannot have one is if the attending or the treatment team determines that it's inhibiting a patient's progress, or maybe you're noticing, hey, after mom comes to visit the patient seems to be especially escalated, and it takes us a long time to de-escalate the patient and get them back on progress for treatment. So at that time, if you feel that visitation is actually inhibiting your patient's progress, they can put restrictions on the patient. I recommend all of our staff chart that, so that way it's clear and evident that the patient may have visitation restrictions, so that way it doesn't seem like it's coming back on individual nurses to make that call each time a family member is coming. Go ahead and get with that attending and get that note in Epic. When it comes to admitting and transferring, this is a big one. So what we like to underscore here is that if you have a patient who's attempting to leave AMA and we do not have EDO paperwork on that patient, it is illegal to hold that patient here in the hospital without that court paperwork being started. And so if you have this coming up, we definitely recommend referring to the policy. So we can have, you know, if you have the time and the patient is willing, they can still meet with the physician, and the physician can then attempt to submit that paperwork to the court. And then if they're in the ED, you can always call a code purple if you feel that it's, you know, in the patient's best interest to go ahead and still try and file that EDO paperwork while they're still here. We do have a system psychiatric support center, which is going to be a cell phone number. We have it, we'll hand it out via email. That's a fantastic resource if you're coming into these unique situations where you can actually process it with a social worker we have here who has a team behind him to say, hey, you know, we're experiencing this situation where the patient is trying to leave against medical advice, you know, don't know what to do, or if you have any situation where you have a psych patient and you feel like you are unsure of what the next best step is, you can utilize this phone number to talk the case through. And so this Senate Bill 359, we bring this up because this has to do exactly with what we just discussed. So this, there was a bill that was proposed that said a physician may have permission to temporarily hold a patient if they try and leave AMA before court paperwork is completed. They were going to call it a physician order temporary hold. That was vetoed. So again, we just want to underscore we do not have the legal authority to hold a patient here against their will if we have not yet filed an EDO. That's why it is so very important to make sure if you have a patient who is here for a primary psych reason, or you begin to think that they are here for a psychiatric reason, and we're starting to get psych involved, and you know, we're starting to talk about mobile assessment teams, that we get that done as soon as we can, so that way we can get these court documents filed. Just because the patient has an EDO on them does not mean that they will absolutely have to go to inpatient psychiatry. A lot of times we might assess a patient and determine, hey, they really do need outpatient resources, but it does grant us that precious time to have them here and have them here at the hospital, so we really can complete a full assessment to determine what's best for their safety. And so going back to our suicide precautions order, so this is one way in Epic to determine if your patient has suicide precautions ordered for them. So what you'll do is you'll go into Epic, you'll follow the directions that are on this particular slide, and you'll wrench in what's called the suicide precaution order. And what will happen is, if your patient actively has suicide precautions ordered for them, this green light will appear, this green dot will appear in the far right column. And so that's an easy way to make sure, hey, verify one, that you've put it in, you've put the order in, and two, just in case if that is ever missed in handoff, you have your own way of double checking right there. And so I'm going to hand it over to my coworker, Brittany. She's going to go over the protocol for the mobile assessment team and our telepsychiatry and give you a little bit more information about what it entails.
All right, so my name's Brittany Hayes. I am our district social worker here at Willowbrook. So I'm the face you'll typically see meeting with the patients. But I'll pick it up with our mobile assessment team. You'll often hear of that referred to as MAT, our MAT team or MAT. They are vital to us. They perform multiple tasks, but most importantly, they assist with the ED, so the documents to hold patients that Haley was just discussing. They're the ones taking paperwork to the probate court for AOCs, OPCs, EDOs, all of that stuff, anything that might be needed in order to legally hold a patient. And they also do a lot of the paperwork and I guess kind of behind the scenes work in terms of transferring patients. If they are not going to be discharged without patient referrals, they're going to be the ones or go-tos for figuring out where the patient can go. So they can also kind of do assessments in terms of patient disposition and figure out which facilities that best suit the patient. Sometimes patients will have certain preferences, so we have to take that into consideration. They have to meet certain guidelines. There's eligibility in terms of if they're going to go to HMH or they're going to Cypress Creek or HCPC. All of that stuff, we leave that to them. They help us out greatly with the transfer, figuring out where patients can go if they cannot be discharged safely. One thing that's important we'll go over, you can call them, but you can also place an order in Epic for a consult with Matt. But knowing the location of where the, which I'll talk about in a second, JSA or telepsych iPads are is very important. But differences between being inpatient on the units versus ED. If you're in the ED, contact Matt before you contact our telepsych services. That's just simply because, like we were discussing, if a patient is wanting to leave AMA, that type of situation, Matt can quickly get the paperwork in place to hold them legally. So JSA, that's what you're going to probably hear most often. We are now with the same people, but it's now referred to as SEC or SCS. SOC, not that. Okay. SOC, but regardless, it's telepsych. So our telepsychiatry, they're great here at Willowbrook and our other community hospitals. At HMH, typically, unless it's in the ED, they're going to see a psychiatrist because we have a psych unit there. Here we utilize telepsychiatry. So, so the Methodist provider will identify the need for a consult. That will be you, like figuring out this patient is tearful, this patient expresses a desire to harm themselves, harm others, or if you just have a feeling that this person could benefit from seeing a psychiatrist, having that time with them. You're going to speak with the attending, and a consult will be placed for telepsychiatry services in Epic. So the RN is going to ask the patient to sign. They have to sign a consent form. They don't have to. There are certain circumstances where if it's best for patient safety, whatever's best for the patient, if the patient will not sign consent, there are certain circumstances where we can still order the telepsych. But in most cases, the patient will sign over consent to see it. But we really want you to know where the telepad is before you, or the telepsych pad is before you start faxing that information over to JSA or SOC or telepsych, whichever to you, whatever, name it. But so what happens is the RN will fax the patient information to JSA or telepsych. And you'll include just basic information, right, in the fax sheet, history and physical. If Matt has already assessed the patient, that will be included. Their information, their findings, the methods, provider's evaluation, labs. Labs are important, especially whenever it comes to transferring patients and meeting the eligibility requirements, all of that stuff. So you will find that in Epic. So just it's to your best knowledge. Use your instincts. If JSA is necessary, patients really do benefit from seeing a psychiatrist more often than not. They're going to consent to it. If they've expressed that they are depressed, if they are scoring high on that PHQ-9, especially if they're feeling suicidal or feeling like harming themselves or others, they will benefit. And the difference between, one big difference, which I don't know if that's coming up in a slide or not, between our mobile assessment team, who can assess patients and kind of give input on disposition of the patient, and our telepsychiatrist is telepsych can actually adjust medications for our patients. So with the patient, let's say if they're going to be here and they're not medically cleared yet, JSA might prescribe them or adjust their medications and then have to reassess in a couple of days. The patient might then be more stable and able to discharge with outpatient referrals. So after faxing, call the unit RN, we'll call JSA to request. We need that telepsych pad with you at that point, because the telepsych will call the unit RN back, and you want to have that with you whenever that happens. If you don't have, whenever they call to discuss the patient, if you don't have that pad with you, you might lose the chance for the telepsychiatrist to see the patient at that time. So, you'll discuss the patient briefly with the telepsychiatrist. We'll bring in the equipment, or you'll call back with the equipment hopefully pretty quickly, so that the psychiatrist can see the patient. Once you get that call back, we just ask that you bring the telepad into the patient's room, introduce everybody in the room, make sure that everybody in the room, the patient is actually comfortable with them being in the room. So if there are, family members, caretakers, or if you get a sense that the patient might be better with just speaking with the psychiatrist by themselves, you can ask for the parties to leave, but it's up to the patient. And also, you don't have to stay in the room the entire time. A lot of nurses, I wouldn't say a lot, some nurses prefer to be in there, especially if they're the person that there's the outcry, or the person that the patient feels comfortable with talking with the telepsychiatrist. But your main role is just to kind of introduce everybody in the room, make sure that everything is introduced, and you are able to leave the room. But if it's a psych patient, we need a sitter there, so that sitter needs to remain in the room. that cannot change. So the MDs assist with med management, like I mentioned. They're able to maybe change up medication, add some medication for patients. They can prescribe that stuff. They have the follow-up calls for behavioral events, and yeah, they make the quickest call for the patient disposition. So most often JSA or telepsychs, treatment plan and their opinion of where the patient is for disposition, that's gonna, come above anybody else's. We highly rely on their expertise. So this slide just kind of explains what it is that I do. I'm flagged to see patients who are obviously, if they're suicidal, I'm going to see those patients, or I'll be meeting with the treatment team that is meeting with the patient. If they score high on the PHQ-9, the depression, anxiety tool that we were discussing, Audit C, I meet with patients that score high for our substance use or abuse, can provide referrals, all of that jazz. And then patients that are scoring high for unplanned risk of readmission. It used to be the D2S2. It's just our high risk readmission patients. And so what I do, I provide, brief assessments, interventions, resources, and then, emotional support. But my main role is, I don't know if I would say main role, but one of our biggest roles is to actually enroll the patient in our program. So the transition of care program. And what the behavioral transition of program does is if the patient enrolls and consents, then we follow up with the patient for 30 days. Our team does once they discharge from the hospital. So that's through phone calls, just checking in, making sure that medications not having negative reactions, that symptoms are improving, that patients are able to make their follow-up visits, that mood is okay, all of that stuff, just making sure everything's going smoothly. And then we also provide one to two, usually just one free home visit. And with that, one of our bridge aides or nurse aides would schedule an appointment, come out to the patient's house, or they can meet publicly. We do it with homeless patients. If we have patients who just simply do not want anybody in their household, that's okay too. But the bridge aides will check the vitals of the patient, kind of speak with them, introduce what's about to happen, and they bring an iPad with them. So they get screen time with one of our nurse practitioners, and then we also have our pharmacists available as well during this visit. But they're really thorough during the home visit. Our role is pretty much to keep patients from readmitting to the hospital, if at all possible. And it's free for the patient, but it's through the Medicaid 1115 waiver. So see if you have concerns about the behavioral well-being of the patient, if you have any concerns at all, and think that they might need some resources for their mental health or for substance use, or you're seeing these are our common patients that we're familiar with. They're, what do we call them?
Super utilizers, typically.
Super utilizers. Then you can place a direct consult to the district social worker, me, through Epic. So it pulls up, this is a direct screen from one of our nurses, and so you'll just hit consult to district social worker, and I'll get an extra flag for that. If I get that notification, that's going to be the first patient I'm going to see that day, more likely. So of course I'm flagged to see suicidal, depressed, any mental health issues, behavioral issues, or readmission patients. But if you put in a direct consult, that I think is the most effective way to get my attention. Particular. And motivational interviewing, I think this is where Marshall picks back up.
Absolutely. We've got two programs here at the hospital that I recommend to everybody working with patients or working, at the human resources level where you're working with people or management level. The first one is motivational interviewing, and we bring in, this is funded by us, it's free to people taking it. We bring in an outside teacher, and it teaches motivational interviewing. So what is that? For those of you who know children, it's very easy to get into a tug of war with kids. Do your homework. I don't want to do my homework. Do your homework. I'm not going to do my homework. I want to watch TV. And in the end, you end up fighting with them for an hour and nothing got done. Motivational interviewing will actually teach you a technique of finding out where the person is, and then you go to meet them at that level to bring them over to change. So if you think of this now, move away from kids and move towards, let's say, a patient. If you suddenly give me a terrible diagnosis, which happens, and even though it's something that we can work with and I can get treated for, I shut down and I'm not listening to you anymore. And so just telling me to take my medicines and do what the doctor says, that's not doing this. So what you have to do is find out, okay, I hear we use reflective listening. I'm hearing you say, I'm so scared of my diagnosis. And now I know, oh, you heard what I just said. I'm hearing you say that there is no help. Who told you there is no help? And so we build on that and we move toward change. You have to know when you're talking to the other person how close they are to making a change. Most patients are in the pre-contemplation. That means I don't know anything, I'm clueless. Or contemplation. I know I have to do this, but I don't know how. I know I don't feel well, but I don't know what to do about it. And so we bring them towards change. The other one is offered by the hospital, CPI, and that is crisis prevention and intervention. And so it's teaching you how to de-escalate a crisis. It's teaching you that if things ever do get at a physical level, what you can do to protect yourself and not hurt the patient. So I encourage you to go for both. Our motivational interviewing program, that got postponed a little bit because of COVID, but when it gets back to normal, we will be sending out announcements, leaders will know, and please send us people. And CPI is offered periodically, and that is still going on despite COVID. Thank you. And I think you're up to our last slide.
Thank you, Marshall. What I think we'll do is I will add on to the end of the presentation, maybe contact information for you all. That's something that you would have typically shared. Thank you guys so much. I think this is going to work out.
I'm glad to do it. First of all, I'm kind of interested in the way this technology works. Are we doing this again today, or is this it?
This is it.
This is it. Well, I hope it worked out nicely. I was going to make a joke. This is the rehearsal. Now let's do it for real. But I think that this kind of gets the message across. And if there's something that I can do to help or we can do to help, just let us know, okay?
I will. If there's something, we can even re-record snippets of it if there are pieces of it that need to be redone. So
Perfect.
yeah, rehearsal. But I think overall, Marshall, I had the screen was being recorded. We got audio from each of the speakers. And then additionally, I had a cell phone recording images of the ladies talking. So I'm thinking I'm going to be able to splice the two together. We'll see.
We're here. So if it comes back and you're like, you can't understand anything anybody's saying here,
Yes,
come back.
which is great. So with that being said, I'm going to shut down the recording and I'll go ahead and I'll end the meeting. But Marshall, feel free
If you think of something or you have a concern about anything, let us know.
Okay, well, I think we got it. If we do it again, hopefully I will have had a haircut afterwards, but that's
Okay.
besides the point. But anyway, I'm glad we pulled it off, okay?
Yeah, appreciate your time.
And realize.
Do it, all right? Be good, everybody. I'm signing off, okay?
Okay, thank you.
Will be doing.
Oh, that in person.
Yes, and this is
Yeah.
just, and our issue was we had 19 people.
Oh,
And we had to put everybody 6 feet